Okay, I think my computer is hanging. I think it's got hot with ROP. Let me ask questions while it again is rebooting. I think the next question was supposed to be on how to dilate these babies. What is the dilatation protocol? I don't know who is supposed to be answering it. Okay.
The dilatation protocol would include the use of phenylephrine 2.5% with tropicamide 0.5 to 1%, or a combination of phenylephrine 1% with cyclopentolate 0.2%. How you're supposed to do it about an hour before, where you dilate the patient either with tropicamide or cyclopentolate in the desired concentration. Put it every 15 minutes, and at the fourth instillation you put a drop of phenylephrine 2.5%, which is generally, if you have a 10%, you dilute it 4 times, or if you have a 5%, as in Tropicacil plus or Itra plus, you dilute it 2 times and just put a drop of that, so that gives you that adequate dilatation which you require. So that's how you dilate the patients.
Yeah, just want to add that now orophenyl comes as 5%. They also had a 2.5%. I don't know, they have withdrawn it. We wanted 2.5% ready-made. So they sometimes supply 2.5% and then they supply 5%, and both are same colored vials. So you have to be very careful. But if it's 5%, then you have to dilute 1 in 2, and you can keep it up to 1 week. After 1 week, the color changes. So then you can't use it. But important thing is to put the drops very quickly. If you give it to nurse, she'll put 1 drop, and then after some hours she'll put 1 drop, it will never dilate.
Also, you can use the commercially available OroPen Plus. It's made by Orolab. They actually call it ROP drops. It has 0.5% already and 0.5% cyclopentolate. So just there are reports about paralytic ileus. At least your pediatricians will scare you.
This is the question I meant for that. Okay.
Oh.
Between cyclopentolate and tropicamide, what would you prefer, Dr. Raman?
Sir, I just use the Orolab drops, and we've now used it for more than 50,000 sessions. We've never had paralytic ileus. I've discussed this with a lot of senior neonatologists. I think the fear has been from the 10% phenylephrine days, that old baggage. With 2.5% phenylephrine, blocking the puncta and wiping off the excess drop off the skin of these babies goes a long way. And we do it sometimes just 2 times, 15 minutes apart. Some of our darkly pigmented irises, despite being darkly pigmented, dilate fairly well with just 2 drops. Sometimes the 3rd drop may be needed.
Okay. I think it's important that the original publications of paralytic ileus from Japan came with cyclopentolate, not with tropicamide. So there was a mistaken impression that it's only cyclopentolate which causes paralytic ileus. But recently there's another publication where they have reported paralytic ileus even with tropicamide. So both of them can cause. I don't know really what to choose between the two. But yes, what you should know as ophthalmologist is that you should tell them very clearly 2 installations at 10-minute intervals and nothing more. After that, you reassess. If really required, you put 1 more drop at risk. But don't let them keep on putting, because doctors will be angry if people is not dilated, and they keep putting the drops until the child develops paralytic ileus, all right? It's because there are children who have been operated for intestinal problems because of the dilatation, which has been inappropriately done, right? So anybody wants to add any other points? All right. So how did you manage if the pupil is resistant to dilatation, Dr. Subhadra?
Usually it's resistant to dilatation means that there is severe NVI and there is a severe ROP. Otherwise, almost all the pupils dilate if the drops have been put correctly on time. And so in those cases, I think I just put 2 more installations and then I start my laser, start evaluating. Because if you depress the eye a little bit, the pupil actually dilates very well. And if you start laser, it dilates fully. And this has been published also. So don't keep on putting drops to make it dilate. Start your work, it will dilate.
I think two important points I just want to emphasize is that here is a situation where the pupil may not dilate well, but you would like to know what is happening inside the eye, at least get an idea as to what is happening inside the eye. So using our ability to use a small pupil ophthalmoscopy is very useful. These are all, now these modern days ophthalmoscopes all can come with small pupil attachments, okay? And you can add on top of it slightly to increase the intrapupillary distance. You will see the fundus much better. And using maybe a lens which is not 20 diopters, maybe 30 diopters, also helps you to see through a small pupil. You'll get an idea. You may struggle a little bit, but you get an idea. And if you know that there is really active problem, maybe these are cases where if you inject anti-VEGF drug, next day the pupil dilates beautifully, right? So some way you can manage this patient without, not with ignorance about what is happening in the back of the eye, all right? Also, in the past, when the anti-VEGF drugs were not available, I was using steroid drops. just for a day, 24 to 48 hours, if I give 4 times a day, the next day people tends to dilate because steroids also have some anti-VEGF property. The people tend to dilate. Because basically, the iris is so soggy with water, it doesn't dilate well, right? And the related question, which is partly answered, is how do we reduce the potential toxicity of dilatation? I think it's partly answered, but if you have...
Already answered, Anand already answered. We tend to put twice only. If after that, don't tell them to put, have a look. And have a look by the magnification offered by going near, and you know it that there is TVL, there are new vessels, so you need not push that. And Anand already said what I have mentioned right in my public, the baby is in the lap. So don't do a mistake of not wiping. Wiping is most important. That's why the toxicity is there. Because full drop, if it remains there, it is going to get absorbed. So wiping is essential. You have to instruct your person who's dilating. So these are some of the things I think which would come.
I have standing
Especially
instruction. If anybody puts a drop without wiping, and anybody, baby or adult, I said you're going to sit here and I'm going to put 5 drops and I'm not going to give you a handkerchief.
Okay, I think the only point I wanted to add is that incident rate is nothing that you have control over. If the child also has an LD block, maybe he is much safer than the child who does not have an LD block because it's not getting absorbed through the nose. Okay. So, what is the examination protocol, Dr.?
So the general guidelines that we follow is the fixed day.
There are slides of yours.
Oh, yeah. So fixed day, fixed time. So if you wait for ad hoc screening, it's good, but then you will miss out. So if you've decided Thursday afternoon you're going to go to a particular NICU, please keep that up. Even if you call up and they say there are no babies for screening, please visit the NICU. Because sometimes you notice that there will be 1 or 2 babies, but then either it's oversight or they think that it was not time enough for the screening to happen. Second most important thing is once you start going there regularly, sort of confidence builds in the system by the nurses and the referring doctors that he'll come, that on Thursday afternoon he's going to be there, and so referrals also improve. So that's one. Guidelines printed out, as other speakers have shown, that's very important. Consent is important. So either develop the consent and give it to your neonatologist to take even before you come, or take it yourself. And as far as possible, do the examinations inside the NICU, or at least in the presence of the neonatologist. I do have some videos on how to mummify the baby, but maybe later.
Okay.
That we spoke about. You can also put in a drop of anesthesia, proparacaine. It helps in dilating faster, and sometimes you can reduce the number of drops of dilatation you need. Sucrose 24%, Australian literature. In our setting, 10% dextrose works just as well. The pellets have to be sterile cotton and then wrapped with sterile gauze. It has to be small enough for the baby just to suck. And it's amazing, it's not just a placebo. Studies have shown that it can cause analgesia. These are an absolute must when you do laser, but when you screen also initially, if you're prodding around the eye and not very confident, it helps as well.
I think at this point, just want to add, there's a recent publication again of expressed breast milk acting as an analgesic. So where you don't want to use sucrose, you can use that. Okay.
As Sir mentioned, any lens, but 20 diopter, 28, depending on how you've been trained. You don't always have to use the speculum to begin with. So zone 1 and even zone 2 posterior can be seen just prize opening. But if you are of academic interest and you want to pick up all stages, then depression is a must. Otherwise, you will not really see the aura in zone 3. And next slide.
I think between the speculums, the Alfonso speculum is what I was very used to, but I find that the tension in the spring of Alfonso speculum is very strong. It really yanks the lids apart. It gives you a very good view, but also is producing a lot of problems with the baby. The baby is very uncomfortable with Alfonso speculum. So if it's possible, use a gentler speculum like what is shown here. And if you really have to hang the lids open, you can use Alfonso speculum. Otherwise, it's really, really violently spreading the lids apart. Yeah. And studies again have shown that if they compared the stress induced in the baby, the stress induced with the speculum is always higher than without speculum.
So the one we use is called the Flynn speculum, named after John Flynn. Also the depressor, not this one, right here. The one you can see that, so can you just point to the speculum on top? Yeah, that's the Flynn one. The way it's flanged out, it's really, really atraumatic. And even if you're using RedCam, the camera doesn't sit on the edge. Otherwise, some of the flanges tend to be solid. And then when you place the edge of the camera, it will create a mark on the lid. Nothing happens, but the mother is fairly petrified and may not come back for follow-up. So it's important to actually give a clean eye when you're giving back the baby. And that's the Flynn depressor. That video may not play, sir, but anyway, so swaddling the baby is very important. There is a particular technique of swaddling the baby. These babies, even though they are small, they are very, very strong. So always isolate their hands. So the first wrap, preferably with linen cloth and not something silky, should go over the entire body, with the legs. Keep one foot out because you want to put the pulse oximeter, and then the first hand will go down, there'll be a wrap, and then the second arm will come out, and then there'll be another wrap. So both their hands are in two different layers of your wrap. That way they are not able to break out of it. This is very important when you're doing laser, and the final fold should go over the head. If you do it really well, they will resemble a cocoon. So the lower part of their body is actually shaped like a boat, and then you should ideally be able to place the baby on a flat surface and turn the baby like this and to actually spin. Don't try it, but that's when you know you've achieved a proper mummification. Mummification, nobody liked the word, so we used swaddle, but that's really the way it has to be done. And then if you do it well, you really need just one assistant to stabilize the head, not even to hold it, because the rest of the cloth is taking care of it. And topical anesthesias. There's just some pictures to show you the screening guidelines. So always face the quadrant that you want to screen first. Ideally, we'd want to see the temporal first, but please see the posterior pole and the macula first, because if you start your depression, sometimes you will cause increased tortuosity and that you might rename as plus disease when it didn't have it. Then, of course, the temporal quadrant, and then depending on your comfort, the other quadrants in any order you wish. These are just some stages, just to show you what they look like.
Any other pearls somebody like to add for examination?
I like to keep the babies fed well and burped. Sometimes people say keep them
I think
fasting.
maybe you can answer this question in your...
Okay.
How would you teach the fellows? Because you have had the maximum experience of having the short-term fellowship for ROP
Yeah, more than
training.
350 now. I have the slides there, you can put it there. So most important
Give me the
thing...
slides.
Slide down. It was there. So I think the most important thing I have learned in ROP screening and teaching is that demystify it. Somehow when I started, it was such an exotic disease which only Gopal can do and Azad can do and nobody else can do. But I can just tell you that ROP screening requires just retinal examination, and every ophthalmologist worth his salt should know how to examine the retina. And in the retina, you just have to look at the vessels. Is the vasculature normal or abnormal? Are they dichotomously branching or they looping? I'll just show pictures. That's all. It just takes 2 sessions with me for people to learn ROP screening. It's not difficult, so what I want to say, demystify ROP. Just teach it like you teach any other retinal or ocular disease. You're teaching thousands of diseases to your residents. Don't make it exclusive. Make it all-encompassing. All my residents, comprehensive fellows, retina fellows, plastic fellows, cornea fellows, everybody learns ROP screening because everybody has to learn how to examine the retina. So that's the most important. And you can use various tools, lectures, brochures, pictures. It's also pictorial. It's nothing like, it's nothing vague. Everything is in pictures. You just look at the vessels. Are they, dichotomously branching? Are they dilated tortuous? That's all they need to learn. So you can do other things. But the most important thing is after teaching what to look at the retina, the other thing is the art of patient care. So some important points like, patient is waiting for 1 hour for you. You go, you have a look. In 2 minutes, you've already screened and you send it out. And parents are very frustrated. They think that, doctor didn't examine my baby well. How can it be that, I came for such a serious disease and doctor just saw and sent out. So I don't do that. The baby is there. I finished my screening, but I don't send the baby out. I finished all my notes and all. I tell the sister, just wait 10 minutes. Let the baby in the room for 10 minutes at least. Otherwise, the doctor will think, so some art, how to talk to the baby. So don't think the baby is not responding. When you are examining, always talk to the baby. It quietens the baby down. If you talk to the baby and the mother is there, you say, oh, your baby is looking very nice. She's wearing nice clothes. So, the art
Maybe
of examining.
Can I request that how exactly you train them? Is there a model on which they practice first before they straight examine the baby, or they examine directly the baby along with you?
Anybody who comes, when they apply for the fellowship or for the training, they've already done indirect ophthalmoscopy on adults. That's one of the criteria. They should be I can't sit and teach them indirect ophthalmoscopy. So if they come absolutely raw, then they have to first undergo 1 month training in indirect ophthalmoscopy. So they must know indirect ophthalmoscopy.
That's the point I would really want to emphasize, that you must learn indirect ophthalmoscopy with ability to indent the eyeball and examine the area where you're indenting. There's no meaning in trying to learn indentation on a small baby. So you learn indentation on an adult or even a model eye, and I know exactly how to do indentation, because despite the fact that it's something many people do routinely, it comes as a reflex. There are many parts of the world where they don't do your routine indentation. You'll be surprised to know that in UK or in Singapore, where I'm practicing currently, the clinics do not have a couch. All patients are examined in the sitting position. So there's no way you can indent a patient routinely unless you take them to a separate procedure room. So that really makes the people not practice indentation at all. So when they have to indent on a small baby, they are really at a loss to know how to do it. So you must develop the ability to indent and do indent ophthalmoscopy before you migrate to examining small babies. That's what I want.
We go about depressing the
Yeah.
eye.
So the idea is that person who comes for ROP training must have at least a basic knowledge of doing indirect ophthalmoscopy. And within 2 sessions, they can start laser if they have done laser in adults. So there are 2 types of people who come for training. Those who are going to only do screening, which is good because that's a large majority of people, and those who are going to screen and laser. So those who have already done lasers in adults, they can start ROP laser within 1 day. There's no difficulty. I push them, they'll say, Madam, I can't see. I say, no, you have to do it. So, they will do first 100 spots, 200 spots, and then they'll say, okay, no more. Okay, fine. In second session, after 2 days, 3 days, they can go ahead and put 1,000 spots. So what I'm trying to say is that demystify, teach them, train them, give them lectures. I spend 4 to 5 hours on the first day giving them a lot of lectures. Within 2 weeks, they get more lectures, and they side by side keep on seeing. So volumes are important. If you don't have enough volumes of babies to see and laser, then it is difficult. But within 1 month, most of the fellows do 15, 20 eyes, and by the time they leave, they can do their own baby, and they have done it. So these are the pictures to show. Most important thing is to pick up the APROP early stage, which is shown right there in the center where there is looping of the vessels. So ROP, I want to demystify, want to say everybody can screen, everybody can know is it a normal vessel or abnormal vessel. Once you have made the differentiation, then you can refer for treatment.
I just wanted to make one comment that you will never miss treatable ROP even if you don't put a speculum. I am different. I learned the way what Gopal said, UK way. I think the Foster probably just used to prize open the lace. So because when I started this, I think the treatable, even Anand probably never put a speculum when he's worked with me for 6 years. But treatable ROP will never. And second time, when you already have made a diagram or you have a documentation, so don't all the time put a speculum. It's very scary for the mother. It's scary for the child. You should put it once you are not sure. But if you put all the time, at least I have not missed any treatable ROP, and I put speculum maybe once or twice in a month. And I started this work in 91. So what I'm saying is that we need to be very, very gentle and need not put in every case if you have already diagnosed, because if you can see APROP, you will see all without. So I think every case doesn't need that. So
yeah, I agree. So when my fellows come for training, first 2 babies they'll put speculum. After 3rd baby, I make it very difficult for them to use the speculum because speculum is on 3rd floor and they have to take the baby there, and in OPD there is no speculum. So they keep on saying, Madam, speculum. I said, no, you see without speculum. You see. And after some time they also learn without speculum. So we don't use the speculum routinely.
So we will ask Dr. Karubi to tell us difficult circumstances during examination. How do you overcome these obstacles?
The examination that you do on a baby should generally be short.
Do we have any slides for this? No.
There are one of the slides, sir. If you can open up that. It should be short, thorough, and it has to be a quick examination. Don't ponder on the child for long hours trying to see. As I agree with both Subhadra and Mangat saying that we don't need speculum for many cases. Certain cases where you have to see very anteriorly, yes, definitely we have to use the speculum and the depressor. For the lasers, we require to give it. If you have to put in a speculum and a depressor, then generally a drop of proparacaine is useful because it gives you that kind of analgesia. 5% sucrose strip before examination or a sugar pellet in the oral cavity helps. Not during the examination, it helps more during the lasers. If somebody is not happy with because the baby is crying or they are a little tense in the initial phases, yes, go ahead and put a sugar pellet. There's no harm to it. In fact, the parents are happy if the child doesn't cry. Glance at the posterior pole. I mean, if you're not putting a speculum, prise open the lids with your 2 fingers, 2 thumbs, and you tilt the head to view other quadrants. So the next.
You want this? Or you want this?
The one. Now, difficult cases when we talk about, if this is a child in the NICU, you see the child is completely strapped like this. And the thing is that you have to examine this child. There's no place to put a speculum also. So you have to gently go in between whatever the contraptions are there, and you have to gently open the lids. If you're finding it difficult, ask somebody else to wash his hands and come and prise open the lower lid while you handle the upper lid, and you have to do a thorough examination in that. Now, if this child were to come to you for a laser treatment, you can imagine how difficult it would be. But then get a smaller size speculum and you can manage it that way. Now, Dr. Mangat will talk to you about how he does it through the incubator wall, because that was his innovation, and it's the most brilliant innovation of all times. So the thing is that is how you do it. But there are other children who may come to you for a laser where the difficult situations are, one, if the pupil is non-dilating. Non-dilating pupils suggest that there is iris new vessels. This is a kind of a rush disease which is there. And the posterior pole also, you will generally find very tortuous blood vessels in the periphery, an APROP-like picture. So in these cases, you generally, if you have to treat, though we have also treated through a 2-3 millimeter pupil, do the laser the first time, the next day the pupil dilates a little more, and then you can subsequently do the laser. But if you want to inject, you can inject early in these cases. These are a few cases where you would inject anti-VEGFs early, because by the next day you get a full dilatation of the pupil. And crying babies, of course, they are easily handled. Or if a child has breath holding spasms, then you just pick up the baby and pat the baby on the back. The child is all right. And once the child is all right, you can continue. Suppose there is a very sick child, as I showed you, and you have to do it in the NICU with a great deal of care. If the monitoring is required for these children, if the monitoring shows that the child is going downhill, there has to be a trained personnel next to you. In these very babies, you cannot take chances with them. You stop your procedure, let them do the needful, ask them to tell you whether you can continue. If you can continue, very well continue. If they say that it's better to stop now, you do it the next day. And then there are children who, while you are examining, go into have bradycardia, or go into apnea. So the simple technique is just that you pick up the baby and just sort of you just what do you call it? Tapped, or you the foot of the baby. So the child then comes around, and once the child is out, then you can carry on with your procedure.